Dr. Tulianis and Dr. Pennington with Advanced Surgeons. Dr. Tulianis, what are the requirements to having bariatric surgery?
Typically use what's called the BMI. It's body mass index. It's a ratio between your height and your weight. We used to use a number 100 pounds over your ideal body weight, but that's so different for somebody who's a little bit shorter, say somebody's 5'4", somebody who's 6'4". So now we use BMI, body mass index, gives a ratio of your height to your weight, and the qualifications, typically a BMI is greater than 35. If your BMI is between 35 and 40, most people have to have some other comorbid condition or other medical condition to qualify. Most patients with BMIs over 40 will qualify without that, though.
Dr. Pennington, what causes obesity?
Obesity is a complex disease. It's not just being lazy. It's not simply just eating too much or not having enough physical activity. At the bottom line, there's a strong genetic predisposition for obesity. So it's a tendency genetically that we inherit from our parents and our ancestors. So that's kind of the starting point. And then the other factors are more social and economic. And what we've seen in Western societies is that as we become more affluent, we can afford food, we have a lot of food choices, they taste great, our lifestyles have become more sedentary. So if you add that genetic predisposition to those factors, then what we've seen is a real epidemic of obesity in most Western countries, and particularly the United States. So for example, back in the 1980s in Alabama, about 1 in every 10 citizens was considered obese. Now, about 1 in every 3 citizens is obese. So the genes haven't changed that much, but what has changed is our work habits, our activity levels, and our calorie consumption.
Dr. Tulianis, are there any other health risks associated with obesity?
There are lots of other health risks, and that is really the indications and the reasons Dr. Pennington and myself as general surgeons recommend surgery for this patient population. High blood pressure, diabetes, sleep apnea, which is a condition where basically you quit breathing at night, high cholesterol. All of those conditions can lead to early heart disease and early strokes, which can actually decrease the patient's longevity. There's other conditions as well, like reflux or even urinary incontinence, which are just related on the intra-abdominal pressures because of the obesity, causing acid to reflux back up to the esophagus, or heartburn, which is how most people refer to it, or even urinary incontinence, which is a little more common in females than males, just unable to control their bladders because of the high pressures. Also, arthritis. Lots of people have low back pain, hip pain, knee pain, and most of those conditions tend to get better with decreasing the stress on the skeletal system by losing the weight.
Dr. Pennington, why would someone consider surgery versus medical or non-surgical medications?
That's a great question. Every year in the United States, literally billions of dollars are spent on weight loss programs, and there are lots of different kinds, some medically, some physician supervised, some not, and there's some very good ones. If you look at the literature, there are a couple of issues. One is medical weight loss programs consider success, their bar of acceptance is a lot lower than surgical weight loss treatments. So they would say that if a patient loses 15% of his or her excess body weight, which if a patient weighed 100 pounds too much would be 15 pounds, they would consider that success in some weight loss programs. And admittedly, that does help resolve some of the medical problems sometimes. But with surgical weight loss, surgical intervention and surgical programs, we're kind of at a whole different level. Most of the surgical procedures we do, like sleeve gastrectomy, gastric bypass, the average excess body weight loss is 50 to 60, sometimes 70%. So if a patient weighed 100 pounds too much, they would lose anywhere from 50 to 70 pounds. So it's quite a difference. And so the patient's health is also improved significantly, more reliably, and more of those comorbid conditions that Dr. Toulianos mentioned, they're more reliably cured. For example, the cure rate for diabetes after surgery, type 2 diabetes, is probably about 90% in most studies. Would be far less than that with medical weight loss. So that's really why surgical weight loss is superior. It's greater weight loss, it's more reliable weight loss. If you have a patient that enrolls that is morbidly obese, they have significant comorbid medical problems, and they enroll in a medical weight loss program, their likelihood of having significant weight loss and keeping that weight off for 6 months is about 5%. So it's about a 95% failure rate.
Dr. Toulianos,
Just expanding on some of the medical reasons to consider weight loss surgery, those comorbidities that Dr. Pennington was talking about, the blood pressure and the diabetes, we have very high cure rates of that, and with those cure rates, we can actually increase longevity by preventing heart attacks and strokes. There's 2 fantastic studies out now in the New England Journal of Medicine, which show that we can increase longevity by 10 to 12 years with effective weight loss and treating the blood pressure, the diabetes, the sleep apnea, the high cholesterol, and thus preventing early heart attacks and strokes.
what type of surgeries do you offer?
2 main surgeries, and I'll start by talking about sleeve gastrectomy. A little simpler approach than is the gastric bypass. And there's a lot of people who think that when we talk about sleeve gastrectomy, there's an implant or something wrapped around the stomach. There's no foreign bodies or no tissues. Basically what we do is remove 2/3 of the stomach, so the remaining stomach that's left is just a sleeve of what was originally there. It works by decreasing the amount of food that a person can eat at one time, and also helps with their satiety, keeping them satisfied for much longer periods so they're not tempted to eat between meals. And so they work by reducing the number of calories a person takes in during the day, and then the body will burn the extra calories and they'll end up losing the weight. It is a permanent operation. We cannot reverse the sleeve gastrectomy because we've removed part of the stomach. But it's a little simpler, like I said, than the gastric bypass, and there's less disruption with medications and less dependence on nutrients, vitamins, and so forth. We still want people taking their vitamins and things, but there's much less deficiency of iron and B12 and calcium specifically than what you would see with the gastric bypass.
John mentioned the sleeve. The bypass is still the gold standard for weight loss surgery. It's the most widely done surgery in the world. Although recently in America, the sleeve gastrectomy has become the #1 surgical weight loss tool. And there are good reasons for that, as Dr. Toulianos suggested. If I had to summarize how these surgeries work, I would say that they do 2 things for the patient. They take away their appetite, their physical appetite. So after the sleeve or after the bypass, the patients are not going to be physically hungry, period, it's a great advantage for the patient. Then when the patients do eat, and we in our program teach them how to eat, we can elaborate on that later. When they do eat, they can eat a very small meal and be satisfied. So contrasting the 2, before surgeries, patients are hungry when they're trying to diet, and when they do eat, they can eat a big meal. So it's difficult to control the calorie intake. After the surgery, they're not hungry, and when they do eat, they can eat a very small meal. So it's easier to control the calorie intake. So we call that, when we do the sleeve or the bypass, we call that the tool that we give the patient. So that's a tool for weight loss. And that's kind of just the beginning.
Dr. Pennington, what's distinctive about Advanced Surgeons' weight loss program?
Well, our surgical weight loss program, and I know John will have some comments on this too, there are lots of ways to answer that question, but we think we are distinctive and we are unique in several ways. First, we have a lot of experience. We've been doing these operations and had a surgical weight loss program since the early 2000s, about 2003, I think. And from early on, we've been considered a center of distinction by Blue Cross and on a federal level or a national level by the American College of Surgeons, which means that we have to meet certain standards of patient care, and we have to have certain results from our surgery to be approved and considered as a center of distinction. So that's one thing that's unique. The other is that we have an office situation that really is not just, we think it's important that patients understand that it's not just the surgery by itself that makes for successful weight loss. It's important that the patient take that tool and use it appropriately, but that's just one component of success. So we have a full-time dietitian, registered dietitian in our office who counsels with our patients every day. We have a personal trainer who teaches the patients how to be more active. And then we have our personal trainer also acts as a mental health counselor. And so what she does in that capacity is she works with our patients to help them identify some of the habits of their lives that would undermine their success. For example, maybe the patient has a habit of eating sweets after meals. So they would identify the problem and they would begin to work on substitution kind of behavior or modifying that behavior so that the patient can be more successful long term with his or her weight loss.
Yeah, and given the amount of experience that we've had, we know two patients are alike, and so all of them need to be treated differently, both in the counseling as well in the operating room sometimes. And just having that experience, seeing a myriad of patients with a myriad of different conditions and problems and so forth, I believe they were well equipped to handle those.
Dr. Touliatis, are there any medical conditions that would prevent someone from having surgery?
Really, no. The short answer is no. As long as patients can tolerate a general anesthetic, if they have cardiac issues or pulmonary issues, if their cardiologist and pulmonologist say that they are an adequate risk, then we can do the operations or proceed with operations. We take this approach because we view this not as a cosmetic procedure, but we view this as a medical necessary procedure. Just as we would treat somebody with a cancer or a sick gallbladder or a hernia, we know that we can treat their diabetes and their blood pressure, their sleep apnea, all those other medical conditions, improve their overall health and longevity and quality of life. And so we really don't turn anybody down as long as we think and their other physicians think that they would tolerate an operation.
Just a couple of comments about that. I think the standard of care is to do these operations in a minimally invasive way, laparoscopically. And so I would say at least 99% of our patients receive that approach. And that is, we're able to do that not just because we have a lot of experience, but also because we screen our patients well, and we have great support here in the hospital with great anesthesia, experienced nurses. We have all the equipment that the patients need pre and post-op, and we designed our program to make it patient-friendly from the initial encounter all the way through the post-operative training and encouragement. I think there are lots of factors that contribute to the success of our program.
Dr. Pennington, are there any options other than medicine or surgery for weight loss?
Well, there are. Let me say that there are lots of things on the horizon that are being looked at experimentally. And there is one procedure that we are doing now. It's called the Reshape balloon placement. And it is a procedure that's kind of in between medical weight loss and surgical weight loss. It is a procedure whereby we introduce a balloon into the stomach, endoscopically that that is with an endoscope. It's done in the operating room under IV sedation, and so the patient doesn't have to have an endotracheal tube, and it's an outpatient procedure. It takes about 30-40 minutes. The balloon is inflated to a certain level, and what it does, it sort of replaces some of the space in the patient's stomach and decreases his or her appetite. So it allows the patient kind of a kickstart, if you will, to lose weight. The average weight loss with this is not as high as with a surgical procedure, the sleeve of bypass, but it is better than with just medical therapy alone, and it's more reliable. Unfortunately, this time the balloon can only stay in for 6 months, but it can be repeatedly placed if the patient so desires. It has to come out, but it can be replaced. Generally, with this replacement balloon, we have a 12-month training program with lots of support, lots of education, exercise program that goes along with it, as well as dietary training and so forth. John might have some other comments about that, but we're excited about that. At this time, insurance is not paying for it, so it's a self-pay option.
That procedure is typically recommended for lower BMI patients, typically BMIs of 30 to 40. Again, it is a temporary placement of the balloon, so the patient is kind of on their own after the 6 months. But that's when we intensify our educational process and our work with our dietitian, exercise therapist to help them maintain that weight that they've already lost. When you compare it to just diet and exercise alone, people tend to lose 3 to 4 times the amount of weight they could lose doing a medically supervised plan without an implant or without a surgery.
The first step the patient needs to take is calling their insurance company and asking the question, do I have bariatric coverage? If there is no bariatric coverage, your insurance company will not approve or pay for this procedure. However, there are times you do have coverage and your insurance has a specific criteria established for them to pay for your surgery. These items need to be addressed and documented before the procedure takes place. The most common items include having a BMI 35 or greater, with diabetes, hypertension, sleep apnea, or CAD, or having a BMI 40 or greater with none of the other conditions. A 6-month diet documented by a physician 1 year prior to having the surgery, cardiac clearance, pulmonary clearance, and a psychiatric evaluation for bariatric surgery. Every insurance is different, and they all require different criteria for bariatric surgery. One of the most common requirements is a 6-month diet with documented efforts prior to having insurance approval. We encourage all of our patients to call the insurance company directly and then call to make an appointment with one of our physicians before you start your 6-month diet, so we can guide you along the way to ensure that you're doing everything correctly. Your medical records must reveal diet adherence before the insurance company will approve for your surgery. Your weight from the 6-month diet will impact decision making and may require a BMI 35 or greater for 3 to 5 years with comorbid conditions. You may also be out of pocket for this surgery with the physicians and the facility. We will be able to tell you the amount on your first appointment. Any deductibles or co-insurance fees are due 2 weeks before the surgery. Some patients have 6 months to financially prepare themselves. We want everyone to be prepared and know their out-of-pocket fees as soon as possible. In our office, everyone will see a nutritionist, fitness, and emotional support counselor. This is not covered by insurance. Our counselors will give you the education and guide you every step of the way. The fee for this program is $300 and it is non-refundable. The fee will be due the day of your appointment with the counselors. Once you find out if you have coverage, your insurance company should be able to tell you the exact criteria that you will need to get your surgery covered. It could take 6 to 7 months for you to have your surgery, or it could take 6 weeks, depending on your insurance.